Hi everyone, thanks for joining us today, and thanks very much for clicking on our video series entitled Cut It Out COVID. And this is a new video series currently being put out by myself as a practicing physician, as an oncologist, and wanted to really focus on a few key things that a number of people, colleagues, both locally in my area, people in my professional network across the country, have been asking me because of my involvement with some of the details in the front line as an oncologist dealing with immunocompromised patients, et cetera, in the coronavirus situation that we're dealing with right now with COVID. And I think that part of what really propelled me to generate this video series is that a lot of what's being said out there, the misinformation, the exaggeration in terms of how healthcare professionals are being impacted, how in control or out of control the situation is, how the healthcare system is being impacted, and the amount of misinformation is so staggering that it's mind-boggling to me. And I think it's one of those things that I think as physicians and oncologists and healthcare colleagues across the country, it's on us to kind of speak up and inform the general public, concerned citizens across the country about what is the real situation out there. And that's really what we're going to focus on, showing you exactly the data, showing you, hopefully in a much more balanced way in terms of how concerned should we be, how the situation is actually much more in control than what people realize out there because of the misinformation that's out there, predominantly by the media, obviously, in terms of what's being put out there. And, a lot of what's out there naturally comes from these news sources that are no longer vetted well. They are no longer researched well. The journalistic integrity has fallen, into shambles, literally. And because of all these factors, the information that we're getting out there, by clickbait type of articles that just want views and want clicks and want that revenue that these various news outlets are generating, is really a shame and a disservice to the people across the country. And so again, I think as concerned citizens, I think it's important to hear some of the real deal information out there, and that's what we're going to show you, and also show you some of the data as well. And I think hopefully you guys will appreciate that in terms of seeing some of the numbers, seeing some of the references, and to show that this is really what's going on right now. And this is not at all to say that we are at all dismissive about the situation or at all belittling the situation as it is. And naturally, we are actually very, very concerned as medical professionals, but to show that, okay, what's going on the medical professional front, the medical science front, the research front, the clinical trial front, the progress we're making in vaccines, et cetera, and how the plan to get the situation under control is much more underway than many of us would be led to believe by some of the messaging out there in the public sphere, such as through the media. So to kick off, we're going to talk in a number of videos, and hopefully you guys will find very interesting, just coming from, what research is available in terms of published literature out there, public data out there, as well as, discussions that I've had with a lot of my colleagues across the country, who are either expert professionals and professors of infectious disease and other professionals in frontline, dealing with these situations. So we're going to focus on two things today, predominantly. Number one is, what is the main problem right now, focusing on the prevalence of the virus, number one. And the second thing is, where are we right now? What is the current situation? What are the next steps? What path are we on right now? And we'll go into some high-level points over here about these issues. And again, going through, showing you some of the data, some tables, figures, etc. Again, without making it too medical schooly. We don't want to make it like overwhelming, just like data that's being thrown at you. But enough that I think you guys will appreciate as intelligent people out there, and people who are concerned about what's happening. And again, because I really believe in a balanced approach to say, yes, we want to go full bore, tackle the medical situation. That's our job, right? That's my job. That's our job as medical professionals, as researchers, to get down to the bottom of it and get this under control. But at the same time, how do we balance all the other pillars of society? The jobs, education, economy, work-life balance, people being able to take vacations for the sake of their own, mental health, their own sanity, etc. And all these things are critical. I mean, I see this as a practicing physician. I see this in my own patients who are coming to see me and coming to talk to me and telling me what they're dealing with on a day-to-day basis, and how stressed they are, anxious they are, how worried they are about their kids going to school and not learning properly, and so forth, because they're being taught virtually, and all these things that are really very, very inadequate as far as the balance, in my view, when I look at it globally in terms of what's really happening big picture society scale wise. So to dive right into it, first, we're going to talk about the prevalence issue over here. So, the biggest thing is that, we see these things that are reported every day, the raw numbers, how many people are new diagnosed cases of coronavirus based on testing that people have done, anywhere in the country. And you see these kind of things like flashed out there, and there are these tickers along the bottom of the news channels and news outlets, not every single one, but many of them. And, there are these counters and tickers that are kind of like meant to alarm the public, because it really is alarming, because the reason is raw numbers in and of themselves are meaningless. And the reason it's meaningless is that without understanding the denominator, meaning how many tests were conducted, and as a corollary to that, what's the breakdown, outpatients, inpatients, symptomatology, etc., without knowing those additional very critical details, the raw numbers are meaningless. Because why? Because we need to know how many tests were taken. To give you an example, and at the heart of the matter over here about the prevalence is that the numbers have to do with the testing that's being conducted. Not that it's a one-to-one, that, it's only because we're testing so we're finding more. It's not to say that exactly, but that is a large portion of what's happening. Because right now we test over 2 million tests per day. If you go to the Johns Hopkins websites, etc., and you look at the number of tests that are being done per day nationally, it's about over 2 million per day. Not every single day. It can be 1.9 million one day, 2.2 million one day, etc. But on average, about 2 million per day. Now, contrast that to the spring, when there were only about 75,000 to 100,000 tests that were being run per day because of lack of testing availability, etc. As well, at that time, a lot of things were being run through very few laboratories, in the country, as opposed to what we have right now. These drive-through modalities through county clinics and primary care offices, and mail-in testing samples to commercial lab companies and so forth. So because of that reason, we are testing 20 to 25 times as many people per day as we did back in the spring. So imagine suddenly we went back to the number of tests per day that we were doing back in May, right? 20-fold less or more. So suddenly 200,000 cases being diagnosed per day drops down to 10,000 cases. And suddenly people will say, oh yeah, well look, we're doing great. We're doing fantastic. But no, we're not doing fantastic. It's not like suddenly things are super. It's just that we're testing dramatically less per day. So the one clear-cut function of this is that the more you test, the more accurate will be the real number of how many people have COVID out there across the country. Because epidemiologists have known this from the early days of the pandemic, especially when they analyzed whole towns of people, especially as was happening in northern Italy, for example, where there were some entire towns that were being tested to say, okay, well, let's say 100 people presented to medical attention because of symptoms, and then let's now test the entire town. And it turns out another 900 people have coronavirus, but were simply not diagnosed because they didn't have enough symptoms, or were even perhaps asymptomatic and never therefore came to medical attention. So because of that reason, we know that there are many more people out there that actually that would be coronavirus positive by testing, but are simply not coming to medical attention. But as we've ramped up testing over the months, since March, April, May to now December, January, we now know that many more people have coronavirus than we originally thought. So that's number one. The raw numbers by themselves are meaningless. Number two is that you have to understand the denominator, which is how many tests are being run per day. That's critical. And so that's why roughly about 7, 8, 9% of tests are positive per day. So therefore, imagine if you have 2.2 million cases, 2.2 million tests that were run on a given day, and 200,000 are positive, that's going to be about 8 to 9%, right? So it totally makes sense that 200,000 people were diagnosed with coronavirus when we know, unfortunately, the prevalence of the virus is such that roughly about 8 to 10% of people in the population are being affected by coronavirus. have contracted coronavirus. And that's been kind of like the estimate that we are seeing not only in the United States, but in most Western countries, Western Europe, etc., Canada as well. That's currently happening. That's currently happening. And what it also speaks to is that as you test more, you get closer and closer to the real population prevalence. The testing numbers, as you ramp up the testing, imagine theoretically you tested 330 million people, the entire United States. You're going to get the real number, right? The real number of people that would test positive for coronavirus. That doesn't mean they are symptomatic. That doesn't mean they're sick. That doesn't mean they're going to die. But that's the real number. So as you test more, you come closer to approximating the real population prevalence. So that's one thing. The second thing that we now know is that as we test more and more people, the majority of folks luckily are either minimally symptomatic or asymptomatic. That's also a big deal, and that's also a critical thing. And that's something that we've seen. For example, that data is available on the CDC website as well as Hopkins website, where they've done estimates as far as how many are outpatients versus inpatients. So fortunately, the vast majority of people that are coronavirus positive will be outpatients and not hospitalized. What do we tell most people? Okay, go home, self-quarantine, let us know if other symptoms develop, for example, and then by passage of the virus with your own immune system combating it, most people will be okay just by that approach. So, and next step is that now what happens when we compare different countries? How's the United States doing as far as compared to Canada, compared to France, compared to Italy, etc., compared to the UK and so forth? So it's quite fascinating. So going off of this point we just talked about, that you have to understand how many tests are being run per day. The United States actually has done fantastic as far as the number of tests that are available per day. In fact, out of the top 30 countries in terms of the absolute numbers of cases that have been diagnosed, right? The top 30, go to Worldometer or any of these standard websites that are out there. Out of the top 30 countries, only one country has tests more on a population rate level. So per million people, how many tests are being run? So in terms of the rate of the testing across the population, only one country in the top 30 tests more than the United States, and that's only by a marginal amount, and that is the United Kingdom. So the UK is the only country that tests more per day on a population rate level, per million people, how many tests are run. Only one country tests more per million people per day, and that's the United Kingdom. So that's very interesting. So that's segueing into the fact that the United States is a very populous country. In fact, we are the third most populous country in the world, right? And it's really staggering, mind-boggling to me that, the only countries that are more populous than the United States, and it's worth kind of reminding people in a way, is that it's only India and China are the only two countries that are more populated in the world than the United States. So because of that, when you compare countries, you have to normalize for testing frequency and population. Remember, imagine that you look at a country like that has, like Australia. It has like maybe roughly 25 million people, right? So imagine you look at if they test far fewer people, per million of their population, and they have a much less populous country, their overall number that are positive are going to be much less than the United States. Whereas if we have 330 million people instead of 25 million people, and we test much more, we're going to be testing at a greater rate, and we have more people, so naturally we're going to get more people that are diagnosed in terms of the absolute raw number. Again, showing why the raw number in and of itself is meaningless, you have to know the denominator, you have to know the country's population. So when you normalize for testing frequency and population, the top 10, top 11 country table is very, very different. And it's actually quite educational and quite informative as far as what happens. And we're going to show that right now. So here is the table. So to take you through it over here, this is from December, just a couple weeks ago, when I went through the analysis over here. But just to show you over here exactly what is the situation. So if you look over here, I listed them by the ranking in terms of absolute cases across the board when I took this data back in early December. Now, the United States has the most cases, India second most cases, Brazil third most, etc. Now, if you normalize by cases, meaning how many cases are diagnosed per million people, and how many tests are conducted per million people. So again, if you look over here, the only other country that tests more per million people is the UK. 642,000 per million versus 587,000. We actually are now up to 700,000 plus per day, whereas we were at 587,000 back in early December. And so when you normalize and take out the normalize for the testing frequency, and you normalize for the country's population, the top 10 list is totally different. So if you look over here, in terms of the normalizing by population and testing frequency, the number one country in terms of the case rate that's occurring in their population is Argentina, by a dramatically higher frequency than the United States. So whereas in the United States is about 7 to 8% of cases that are positive per test that are taken. So out of 100 tests, about 7 to 8 are positive, versus in Argentina, out of 100 tests, 36 are positive. A much higher testing positivity rate. So quite different. So by this, re-ranking, when you normalize for population and testing frequency, because again, those factors are crucial. You have to know that in terms of saying, well, how in control or out of control is it in a given country, coronavirus? And this is much more informative and much more accurate in terms of understanding the real rate of positivity that's occurring in the population of a given country, when you normalize by testing frequency and normalize by population. So the United States, by that measure, it falls to actually number 7, because Brazil, 28.97%, France, 10.78%, Argentina, 36%, Colombia, 20.5%, for example, are higher, as are Italy and Spain by a slight amount as well. So now if you zone in now on the more Western European countries, for example, and you can see over here that our rate is actually comparable. Look at the United States, 7.15%. You can see over here France 10.78%, Spain 7.24%, UK lower at 3.76%, Italy 7.33%, Germany as number 11 at the time, 4.26%. So when you look at that, the United States is actually at a fairly similar level in terms of the testing positivity rate, but again, we have many more people, and compared to all these countries, and we test at a much higher rate. Besides the United Kingdom, we test at a much higher rate than everybody else as well. So because of that reason, when you normalize by population and by testing frequency, the U.S. is actually comparable to other Western European countries, and it falls to number 7 in that ranking, for example. So that's number 2, as far as that goes. So I think that's very informative. Hopefully you guys will find that useful as well. Now, a related point is that, okay, roughly right now, about according to the data that's out there, from Hopkins and so forth, is that roughly about 7.5 million people are coronavirus positive currently. Okay, so now putting in perspective in terms of the percentage of the population, and this is again balancing the society's needs, the pillars of society, education, jobs, work-life balance, vacation, mental health, etc., along with the medical side, of course. So about 7.5 million people have coronavirus currently across the United States. So when you talk about a country that has 330 million people, you're talking about 2%, slightly more than 2%. So 2% of the country approximately currently has coronavirus, meaning that 98% of people do not currently have coronavirus in the country. 98% do not have coronavirus in the country right now. So 90 out of 100 people in any given place, averaged obviously, some places have more, some places have less, do not have coronavirus. So for example, in North Carolina, less than 1% are coronavirus positive currently in beginning of January 2021. So 99% of people in North Carolina right now do not have coronavirus, walking around diagnosed coronavirus, for example. Not that other people may be undiagnosed and may perhaps have it, but as far as officially diagnosed right now, that's what the numbers are currently in terms of official diagnoses. So I think that's very informative as well. So that's also one more reason why, again, I think that there's a real pathway where we can go full bore on the medical side, researching and studying and taking the right measures to control population infectivity and so forth. Like crowd control and requiring masks in the right stores and but not necessarily everywhere. Allowing kids to potentially go to school, if the right setup is available, for example, and doing all these things in a smart way and protecting those that are most vulnerable. Because now we know who is also at high risk of complication and who is also conversely at low risk. So therefore, with this much more nuanced understanding that we have now, we can, in a much more surgical fashion, so to speak, much more targeted way, protect those that are vulnerable and allow the rest of society to go about their business, albeit with a few common sense, straightforward precautions. Excellent hand hygiene, avoiding large crowds, and in those places where it's appropriate, wearing masks, say like a crowded store where you can't, avoid, other customers and so forth very easily, like a post office. Post office will be crowded with 20 people in close quarters, for example, and you can't really realistically keep your distance from them, obviously, in that circumstance. So because most people, 98% of people in the country do not have coronavirus, I think it is feasible to follow such a path while addressing the medical side very properly and thoroughly, but also allowing most of society to continue to function. And I think that really is crucial because of how long this is going on and how much this is affecting everybody's lives. So segueing now to the what is the risk by population, and this is also very, very informative, and this is published in PLOS Medicine from just a couple months ago, which is one of the reputable journals that are out there, peer-reviewed medical literature out there. Public Library of Science Medicine is what the full thing stands for, but PLOS Medicine, very standard journal. And based on that, the CDC published data, and this is not from the CDC, but rather what researchers have analyzed, again, published in a peer-reviewed journal in PLOS Medicine, taken from data from multiple Western European countries, Canada, as well as China as well. So that's what they had, and I'm going to show you that data in just a moment over here. And here it is. I took a screenshot over here just to make it easier for display purposes. What you see over here is the infection fatality ratio estimates based on that publication and that research effort that has been conducted, as well as other data that's been incorporated into that analysis. So what you see over here is that they give a number of scenarios, and you can see the best estimate, circled in red, as you can see, obviously. So here it takes what's the infectivity, which is the R0 value, and what is the breakdown by age based on real numbers that have been, what has actually transpired, in the world currently. So in Western European nations, Canada, etc., and they excluded the Chinese experience in this analysis because the researchers felt and the CDC felt it may not be reflective of the American population necessarily because of differences in terms of their system compared to the United States and Western Europe, for example. And as you can see, these are the numbers, meaning that if you contract coronavirus, this is the risk of actually dying of the infection. So that's what they mean by infection fatality ratio. And that's why we care about infection fatality ratio very much, because that ultimately tells us what is the risk of dying from that particular pathogen, across the board. And not just like the sickest of the sick that come to the hospital, for example. So as you can see, a huge driver of this, the biggest driver of this, is age. So 70 plus years age, the infection fatality ratio is 0.054. But if you look at 20 to 49, for example, it's 0.0002. Younger than that, 0.00003. So you can see this is the best estimate currently based on real world data as far as what is the real risk of dying if one were to contract coronavirus. So what that means is that you have to first contract coronavirus, and then these are the risk of dying. So again, if you're one of the 2% in the country across, average across the country, if you're one of the 2% of the country who currently have coronavirus, then this is the risk of actually dying for it. Meaning that if you're a person right now, let's say you're a 45-year-old person in the country right now, anywhere, whatever state you're in, and the risk of you contracting coronavirus and then dying from coronavirus is the multiplication of the risk of actually contracting it, about that 2% population rate, and then that infection fatality ratio. So to take you through it real quick over here, I'm going to take you through the multiplication right now just for the sake of illustration. So imagine you're one of the 2% so imagine you don't have coronavirus right now. Let's say you're a 45-year-old person in the country, and you wonder what's your risk of contracting it and then dying from it, right? If you're just in your house right now watching this video. So it's 0.02, meaning 2%, times the infection fatality ratio. So the infection fatality ratio for somebody who's 45 years old is 0.0002. That's the risk of dying of coronavirus if you have it. So meaning that you wound up getting, unfortunately, a very severe case of coronavirus infection, pulmonary infection and so forth, and you died of coronavirus. It's 0.0002 is the risk. So that comes to 0.000004. So 4 times 10 to the negative 6 over here is the risk of actually dying of coronavirus, meaning contracting coronavirus and dying of coronavirus. So to put it into percentage, you would multiply times 100. So meaning just for the sake of discussion, 0.0004%. So your risk right now of if you're a 45-year-old person in the country, just as an example over here that we're talking about, of contracting it and then dying from it is 0.0004%. So again, I think that it's not to say that's good, bad, or anything else. It's just that this is the real data. This is the real risk of it. So when we put into the perspective in terms of the whole society, the society's needs, for example, in terms of work, education, work-life balance, vacations, everything else in society that we have to do, I think this is very informative to say why I really believe we can work in a much more targeted fashion, protect those that are really vulnerable, the elderly, people with high-risk conditions, immunocompromised patients, etc., like what I deal with in cancer patients, for example, while letting most of society go about their day-to-day lives, again, albeit with a few straightforward precautions, avoiding large crowds, excellent hand hygiene, etc. And you can see the risk of actually contracting coronavirus and then dying from coronavirus is thankfully very, very low. And that is quite informative. And I think that's where we really have to, keep this perspective smartly in mind when we devise what's the policy, what's the approaches in the community, across the country before we cripple other institutions across the country because of misunderstanding of the risk of the infection. And again, this is all from published literature. This is all public information that's objectively verifiable. You can look it up yourself very easily. As you can see over here. And I'm gonna put into perspective what was published in a different journal where they looked at what is the risk for people who are younger than age 70, younger than age 65, I should say, and do not have one of the big conditions of, as far as the big comorbidities for risk. Obesity, immunocompromised status, significant cardiovascular disease, significant pulmonary disease like emphysema, for example. If you don't have one of those big risk factor conditions, then what is the risk of dying if you're younger than 65 and don't have one of these conditions? So here's a study, and this was published in Environmental Research back in September, and they looked at, as the title says over here, population level COVID-19 mortality risk for non-elderly individuals overall and without underlying diseases in pandemic epicenters. So published out of Stanford, Department of Epidemiology, one of the most prominent places in the country. And to take you to the specific section I want to show you is over here. So what they found in their analysis when they looked at actual mortality for individuals less than 65 without one of those significant comorbidities was this, and sorry about that right there. So you can see over here that the risk of people who are less than 65 years old in 11 of the 12 European countries that were analyzed, as well as Canada, was equivalent to driving between 12 to 82 miles per day. So meaning that is the actual risk of dying. It's equivalent, to put it in a perspective that maybe can resonate with people is that the risk of contracting COVID and dying from COVID is equivalent to the risk of approximately driving between 12 to 82 miles per day. These kind of vehicular mortality statistics are available in public websites in most countries in Western Europe and Canada and the United States. So it's equivalent to driving less than 100 miles a day. So not that it's a zero risk, but the risk is fortunately pretty low. So just like we talked about in that calculation just a few minutes ago, is that fortunately the risk is pretty low. So again, one more reason why here are the real numbers. That is the real mortality risk, for most people. So yeah, we have to take precautions. We have to be careful. We have to use excellent hand hygiene. We have to avoid crowds. That's fine. But that doesn't mean we shut down restaurants. That doesn't mean we, do all these kind of measures, prevent, kids from getting proper education for months on end. While going into this, effort to control the medical side. The medical side is actually, thankfully, the progress is far more along the way than what it would, one would be led to believe by many outlets across the country. So, segueing now to the last part of our discussion is that what are the goals right now? I think the biggest goal right now is a return to normalcy, right? And not that that's going to happen overnight. I'm definitely not saying that. But, are we on that path? Returning to normalcy. And secondly, with that is how do we continue to make progress against coronavirus while protecting the vulnerable? The vulnerable are those that are at higher age, 65, 70 plus years of age, do have higher risk, like we showed in those infection mortality tables a few minutes ago. And secondly, those that have the significant risk factors like cardiovascular disease, pulmonary disease like emphysema, immunocompromised state, obesity, etc. So by protecting the vulnerable and continuing progress against coronavirus, we are definitely in a much better position to return to normalcy in the coming several months because of this particular situation. So as far as where we are right now, with the ramped up testing that we have done, number one is that we fortunately have a much better understanding of what's the prevalence, what is with these other analyses that we just talked about, the mortality risk for people, and who is at risk and who is at low risk, And again, it's not that a 45-year-old person doesn't have any risk, but their risk is low. And like anything else, we operate based on probabilities, right? I mean, you go to work, on a given day, you travel, you go see a friend, all these kind of things. There's some risk every single day of, anything can happen, unfortunately, not to be morbid, but, anything can happen. So I think that's where we have to keep those things in mind to say, yeah, there is risk, but the risk is quite low, as we just talked about, and what's available from the real data that's published out there in PLOS Medicine, in the Environmental Research Journal we just talked about, and other, common websites like the Johns Hopkins, analyses where they're collating data on an ongoing basis. So because of the testing frequency and because of the studies that have been done, the remarkable amount of study that's been done over the past several months, we have a very good understanding of where things are right now. And so because of that, I think, again, we can operate in a much more nuanced fashion to allow people to work, allow kids to go to school, allow, again, with certain precautions, not like a free-for-all kind of like, without any precautions. Absolutely not, but with the proper precautions, avoiding crowds, wearing masks where appropriate, excellent hand hygiene, and, and then by doing these things, we can really go about and address society's needs in a much more balanced way than what's being done right now in, unfortunately, way too many places across the country. And the last critical point is that the vaccines are here, right? I mean, the vaccines have started already since mid-December, vaccines have started. So December 11th was that Friday was when the Pfizer vaccine got approved, and by that following week, we started getting the vaccines, including in my area, physicians have been able to start getting the vaccine. And with the vaccine, that we'll talk about vaccines in much more detail in a future video, but a vaccine that's highly efficacious, 90 to 95% reduction in contracting COVID with almost zero numbers of severe COVID cases. So not that it can't happen, but your risk goes down dramatically with vaccines being utilized. And the vaccine, it's not that vaccines are suddenly all great versus not good, but the overall risk benefit ratio does make sense for those that are at high exposure and high risk. So not that every single person, but for the people who are at high risk of exposure, like doctors, like nurses, other people in the public sphere, flight attendants, for example, where they will see hundreds of people a day, and at the same time, those that are at high risk, like the elderly. So giving those particular groups extra confidence by getting the vaccine, reducing the risk substantially, and therefore they can go about their daily lives much more safely, especially those with the comorbidities and the elderly, for example. So to show you one last figure over here, which is going to be the figure just showing some of the historical vaccine program efficacy and how much of a difference it's made, historically, is this figure right here. So what you see over here, and this is just from a standard immunology textbook, where we see some past important vaccine successes. So, for example, against diphtheria, childhood diphtheria, after introduction of vaccine, as you can see, a very, very steep drop-off in the coming years as the vaccine rolled out. And back then, the vaccine was rolled out much more slowly than is being done currently with the COVID vaccine. Especially for the, in the phased tier grouping that's being done, that strategy that's being utilized. Polio, very similar. Polio was a significant scourge. Obviously, people will be crippled with polio for life, like FDR, for example, and other prominent figures. And you can see, look what happened after the inactivated vaccine as well as the oral vaccine. And now it's almost a historical relic, you can almost say, which, thankfully, this kind of success rate is possible with things like vaccines. So again, it's not to say that every single person has to get a vaccine suddenly, but I think that it does make sense for the high-risk groups and the high-exposure groups for sure, and the risk-benefit is probably better for them in that setting as well. But when you put it all together, when you normalize by testing frequency and by population, the U.S. is actually doing overall fairly good. When you compare to other Western European countries, France, the U.K., Italy, Spain, etc. So Canada as well. So that's number one. Secondly was the prevalence, where roughly about 2% of the country currently has coronavirus, so meaning that 98% of people do not have coronavirus. Most people have a very low risk of contracting COVID and then dying from COVID. So you have to be one of those 2% in the first place. Then you incur that infection fatality ratio we talked about. Like for somebody who's between ages of 20 to 49, it's 0.00002, is the infection fatality ratio. So the average person who's out there who doesn't have, who's not elderly, doesn't have high risk factors, your risk of contracting COVID and then dying from COVID is thankfully very, very low. So again, why there is very, very strong evidence, published evidence, public data that's easily objectively verifiable, like from the Hopkins websites and so forth, that in a much more balanced and targeted way, we can meet the needs of society, like work, like education, like allowing people to have better work-life balance, addressing mental health issues as well, by giving that normal balance in their life without compromising the medical efficacy as well. So because of the way things are right now. So therefore, I really think we can be much more optimistic than the kind of message that's been received thus far. So yes, it's a problem. Yes, we have to, using all our medical resources, our collective wisdom, our collective ideas, to put a successful end to the coronavirus, being a prevalent virus in the world as fast as possible. And we are doing that. I mean, the prevalence is significant, and that's why that really is the biggest problem, why we have to address it. I mean, if only 100 people in the world had coronavirus, regardless of the mortality, we would say, okay, well, ultimately it's not affecting the overwhelming majority. But unfortunately, so even though in spite of all these efforts that have been done so far, the prevalence is significant enough where we've come to the point where things like vaccines are needed for the high risk, the high exposure people as well. But the prevalence is the number one problem, but it's still within control. 2% of the population currently has a diagnosed COVID case in America. Number one. We talked about how the infection fatality ratios are fortunately low for the vast majority of folks out there. So because of this balance, there's no reason we can't be optimistic, continue going full bore medically to get it under control. And again, that's our job. That's what we're working on. And by doing these things, we can, I can really foresee that we're going to be able to successfully get the COVID numbers down dramatically, where we can really go about our day-to-day lives, even starting now, but especially for those high-risk, vulnerable people like the elderly person and so forth, they can even, get back to more of a normal life themselves as well, because of the track that we're on right now. So we really are on a good track, because of all these reasons. So thanks very much for paying attention today. That's the crux of our video today. Trying to outline some of these big picture points over here that I think really are hopefully very informative for you guys, as well as useful for your understanding. And again, what I like is that all this stuff it's objective information that anybody can look up themselves. Anybody can go to these websites and go to these journals. And sometimes the journals are paid kind of access journals, but they are all accessible by the public. And I think that's what's great, is that when you look at it and move beyond the noise, kind of like what that intro statement we had said, why I think this is very important for us as physicians to speak up when we see what's going on with the mismessaging, the exaggeration of information out there. And we're going to address several other issues in the coming, videos as well. And stay tuned for our next video, where we're going to focus on the problems with mortality estimates, how in-hospital mortality has actually dramatically improved compared to the spring. So I think this is also very, the problems with testing, the problems with mortality estimates, and how things are actually doing much better in terms of the hospital mortality as well, thankfully also. So stay tuned, tell any friend that's interested in learning the inside scoop. Again, this is all from objective, verifiable data, which I think is the great part, is that we have access. In our society, we have access to this kind of information. Anybody can look it up. Sometimes it might require a medical person to perhaps put it into perspective, which is where hopefully this is helpful, in that regard. But again, that's what I really like. And, lastly, knowledge is power. And a corollary to that is that accurate knowledge is power as well. So with that, I really appreciate you guys listening and tuning in, and hopefully you guys found it useful. Hit the subscribe button, hit a like if you can, whatever's helpful. Tell a friend, share with a friend, anybody interested as a concerned citizen for what is happening in the country and how we can do better, and not just in a cowboy kind of fashion, but really a data-driven, what's objective information, the real deal of what's happening out there. So tell a friend, spread the word, and stay tuned for the next one. And again, really looking forward to it. See you guys soon. Really appreciate it.